we have done a small role play to depict how AMSP works in a hospital. So, we have shown AIIMS Hospital Patna here. The administration, commitment and accountability is in place with policies like antimicrobial stewardship policy, diagnostic stewardship policy and the infection control stewardship policies. The clinician with JRs are present in the emergency department and they are discussing a case. A patient is seen arriving. The patient looks sick. The doctor asks the patient attender as soon as the patient comes to get the file made, and they start checking the patient. They make the patient shift to the bed and they examine the patient. The JR notes down the vitals of the patient after checking, and the blood pressure for this patient is 90/60. The random blood sugar was noted 500, and there is a history of fever since 7 days, dry cough since 3 days, shortness of breath since 1 day, and dysuria since 3 days. They note down the blood pressure and other things, and also the treatment is started for diabetic ketoacidosis along with injection linezolid and colistin. The clinician notes down the diagnosis and he makes a diagnosis of diabetic ketoacidosis with LRTI with right-sided pleural effusion with a query of UTI, and he writes that patient is under septic shock. It was seen, the ABG report was seen with the patient is with metabolic acidosis. He tells the patient attender we have admitted the patient to MICU. So the treatment has been started and we are sending some tests to know the status better. We may change the treatment after that. To the nursing staff he tells to send us some tests. So he is sending pleural fluid, sputum for gram stain and culture sensitivity, blood and urine for culture sensitivity, and some other regular tests for knowing the metabolic status of the patient. He sends a message on WhatsApp group. There is an antimicrobial stewardship group, so he sends the patient details with samples sent and asks for an urgent report to the microbiologist. 2 hours later, the microbiologist has replied and the report is sputum gram stain shows salivary sample, the Bartlett's cyst salivary sample, and it shows occasional pus with GPCs in chains, and pleural fluid gram stain shows no pus, GPCs in chains. Urine microscopy shows 2 to 5 pus with cellular cast seen. No other findings are there and culture has been put up. Next, the pharmacologist is seen texting the clinician. He asks why is linezolid started in the first line. The reply from the pharmacologist comes risk factor for MRSA. He asks why not vancomycin. Why? The clinician asks why are you advising against linezolid. The pharmacologist tells we are preserving linezolid for MRSA and VRE, and also it is used for TB, so we are preserving the drug. So the clinician asks, okay, should I change now? The pharmacologist tells if there is no contraindication for vancomycin, then please change linezolid to vancomycin. The pharmacologist and microbiologist go and take rounds in the wards. So the pharmacologist comes. The pharmacologist and microbiologist comes to take round in the ward. The pharmacologist checks for the dose, drug and delivery, and he notes down in the file to change linezolid to vancomycin as discussed, and he also notes down to mention the duration. He fills his ASP form. In the meanwhile, the microbiologist ensures waste management and standard precautions. She checks for the bundle care, hand hygiene and needle stick injuries etc. in the checklist. She checks the antibiogram. The pharmacologist notes his ASP form. The microbiologist goes to check the waste management. If the biomedical wastes have been discarded appropriately. She also maintains hand hygiene. And she notes she makes a note of the nursing staff about collection of sample and hand hygiene. She checks the antibiogram and adds a note to change colistin to peptase, as the local antibiogram suggests diabetes mellitus with UTI. The most common organism seen is E. coli, which is sensitive to peptase and amikacin, with MRSA sensitive to vancomycin and linezolid. So she makes a note of that, and she ensures sample collection is proper and hand hygiene is followed strictly. So the clinician after that changed the antibiotics as suggested. After 48 hours, the clinician, microbiologist and pharmacologist meet. The clinician, microbiologist and pharmacologist come on rounds and they discuss about the drugs and the follow-up decisions. So the pharmacologist tells the clinician that drugs are to be continued for 7 days, that injection vancomycin and peptase. And microbiologist informs the clinician that urine has shown protease growth, and protease is intrinsically resistant to colistin and beta-lactams. So it's good that we had de-escalated colistin to piperacillin tazobactam. Pharmacologist does a prospective audit and feedback. So the same drugs were continued and the patient showed improvement. After 7 days, they all follow the hand hygiene practices. After 7 days, the ascitic fluid and blood culture report has come, and the culture sensitivity report has shown no growth, that is, the fluids were sterile. So the patient is getting discharged now. The clinician educates the patient to maintain hygiene, take care of her diet, revisit OPD after 7 days, and do vaccination if required. He gives the discharge form to the patient and explains everything and calls them to visit OPD after 7 days. The clinician completes his ASP form and prepares for ID meet. The pharmacologist and microbiologist check-in. Pharmacologist does a prospective audit and feedback, and microbiologist enters the data in Excel sheet, prepares cumulative antibiogram and enters the data in WhoNet and prepares for ID meet. So we come to an end of the play, and I hand over the mic to Dr. Vinod Pati sir for the panel discussion. Thank you, sir.